Patient-Centered Care, April 2nd. Kate Foreman, welcome.
Thank you, Tim. It's nice to meet you again and to be here to give a talk.
Well, we are really looking forward to it. Let's find out a little more. We're not going to read all of that, but we are going to say that in addition to clinical work, that you serve as the vice chair of the UNC IRB committee, and that you helped identify the need for pediatric cancer patients at UNC and started the Pediatric Cancer Genetics Clinic along with Bradford Powell. Provided clinical supervision for over 30 genetic counseling students and 6 medical genetic fellows. Was the 2015 recipient of the Pacesetter Award from the UNCG School of Health and Human Services. This award honors outstanding alumni who have attained local, state, or regional recognition through their achievements in scholarship, leadership, and or service during their career. Belated congratulations.
Thank you.
And created and teaches GEN 615 Introduction to Oncology and Genetic Counseling, which is now a core course of the UNCG Master of Science in Genetic Counseling curriculum. What's something else outside of your professional bio we should know about you?
Well, I have 2 young daughters. They're 8 and 4 years old, and both of them are in Taekwondo classes. So
Wow.
My current hobby, since that is not something that was ever on my radar, is learning about the practice of Taekwondo and scoring. So I can support, especially my oldest, she's on the tournament circuit now. So I'm learning all about sparring and combat weapons and things that I never thought I would have to learn.
Yeah, well, good for you.
That keeps me busy.
I'll bet. Good for you for doing that. I'm sure they enjoy that. The question, here we go. The BRCA1 and BRCA2 genes are associated with significantly increased risk of colorectal and endometrial cancers. This is a true-false. Think about it carefully. It's a true-false. And then while, let's see, there is the answer opportunity. We're seeing a true, we're seeing a false. We're going to give this about 15, 20 seconds. I don't want to give anything away, but I will say that an awful lot of the time these true-false questions at the beginning are true. But that doesn't mean they're always true.
Yeah, I might have tricked some folks, and that's okay. We're all going to be learning today.
All right. So how are they doing?
So we've got a solid 30% that recognize that this is false so far. These genes are actually most known for their increased risk of breast and ovarian cancers. Endometrial and colon cancer can go together in the same syndrome as well. It's just that that's Lynch syndrome, different genes, different condition. So I think you're recognizing that there's hereditary risk there, but maybe not yet knowing the alphabet soup of how we name different genes. BRCA1 and BRCA2 give us a clue, though. The BR stands for breast and the CA stands for cancer. So these genes, when they were discovered, were named breast cancer gene 1 and breast cancer gene 2. Not all genes are as helpful as that in telling us what they do.
And Kate, you got me too, because I started to answer this earlier when I was going over this with Drew, because they're always true. And then I thought, wait a minute, I don't think about the BRCAs especially with endometrial, and I went and did some Googling.
I went rogue. I went rogue.
Good for you. Good for you. All right. Well, genetic testing for cancer patients and family members, recommendations, and Kate Foreman, MS, and then CGC. That's
Certified Genetic
Counselor. Good deal. All right. Well, you've got the controls, and we'll turn it over to you.
All right. Well, thank you for spending your time with me today. As Tim said, I'm going to talk to you about genetic testing for cancer patients and their family members, and I have some recommendations for you. But I'm going to start off with a question. Maybe it's a question that you had yourself when you heard the talk title. If a person has already developed cancer, what even is the utility of diagnosing an underlying hereditary cancer syndrome? And to be honest, our scheduling team hears this same question from patients frequently. I'm sympathetic to that view. Patients with cancer already have so many medical appointments. They are taking time off work and everything else. Do they really need to make room for one more appointment with us? Or if they're getting their genetic testing in the context of their medical or surgical oncologist's office, is there time to talk about genetic testing in addition to treatment options, prognosis, and everything else that has to be happening in those clinic appointments? But I hope that you'll agree with me after today that yes, this is something that's important for patient-centered care, because patients have questions about their cancer diagnoses. They want to know what is the diagnosis as specifically as possible. They're often interested in knowing how it happened. Why is it that they, rather than someone else, ended up with a cancer diagnosis? They want to know what they can expect, either the prognosis of their current cancer, or if they survive their cancer, what's the chance of a future cancer? And is there anything they can do to mitigate their risks, to prevent more severe disease? And really, a lot of patients are motivated by knowing who else in their family may be at risk. People have a sense that when they or a loved one has cancer, there is a higher chance for that in others in the family. And so that's often at the top of their mind, in addition to thinking about their own treatment, is how can they help other people in the family avoid this? So genetic testing helps us answer the first question to the best of our ability. What's the diagnosis? Is it sporadic cancer, or is it cancer in the context of a hereditary cancer syndrome? And only after we can answer that can we answer the remaining questions. So today, I've been asked to really focus on the relationship of genetic testing for both cancer patients and their families. We are focusing on the last question here, but certainly cancer genetic testing can inform all of the questions that are listed. So these are my objectives for you today. I hope to help you recognize signs of hereditary cancer risk to identify patients who may be in need of cancer genetic testing. I hope that you will be able to explain the benefits of testing an affected person prior to testing their unaffected relatives, so that you can explain this to other members of your team or even to the patients themselves. I'm going to give you some ways to support patients in communicating about genetics with their relatives and help you identify situations when a patient or relative may benefit from referral to genetics. So I think it makes sense to spend a couple minutes talking about what it really means for cancer to be hereditary. I like to acknowledge that all cancer involves genetics because something has changed in the genes of that cancer cell to change it from a healthy cell into ones that has the properties of a cancer cell. But most of those genetic changes are not hereditary. And really, hereditary cancer is a misnomer, right? We don't actually inherit cancerous tumors. It's more accurate to think about this as hereditary risk for cancer. When I say hereditary cancer, I am typically going to be referring to single gene or Mendelian syndromes, known for Gregor Mendel, the guy who studied pea genetics. And these are things where a single gene is altered, and that single gene alteration is sufficient to cause an increased risk of cancer. And that increased cancer risk is enough that that patient needs to be cared for differently than others that don't have a similar risk. That being said, I also want to acknowledge that sporadic or multifactorial cancers can also have a hereditary component. So it might be helpful, instead of thinking this as a black or white issue, as thinking that when we say hereditary cancer, the genetic hereditary contribution is the strongest. When we say familial, it may mean that we didn't identify a hereditary cancer syndrome, but the family still seems to have more than its fair share of cancer. And then sporadic would have the least hereditary contribution, where there don't appear to be signs of cancer clustering in the family. For those of you who are more visual, I think this diagram also helps explain some of this. You can think about each of these cups as a different person and their ability to tolerate cancer risk. So if the cup gets filled up all the way to the top, that's when a cancer would develop. Inside the cups are marbles of various sizes and amounts, and those are representing the genetic risk factors that that patient is born with. Those are largely unchangeable. Whereas all of the non-genetic risk factors are the water that's going to fill up the nooks and crannies and eventually fill that cup up to the top. So one thing to notice is that even the person with a hereditary cancer syndrome, which is represented by the largest marble, they typically do not have a 100% chance of cancer. So that's a common misperception that if there's hereditary cancer risk, it means someone would definitely develop cancer. But in fact, all of the other common causes of cancer, like the radiation we're exposed to in our environment, are behavioral modifiable things like diet, exercise, smoking, and other toxins that we might be exposed to. Those contribute as well, just in a more minor percentage than they would for sporadic risk. We also have some middle-sized marbles. In cancer genetics, we often think about risks as being high penetrance or moderate penetrance, penetrance referring to whether or not someone develops a cancer. And our modern genetic tests will find the big marble and the medium marble risks. But it is important to recognize that in 2025, genetic testing does not identify polygenic or multifactorial genetic risk like what we see in cups 1, 2, 3, those little marbles that we know contribute to why genetics can influence cancer even when our genetic testing comes back normal. That is just a limitation of current testing. But if you look at cup 2 and cup 3, both of those people have a similar level of risk in this diagram, but the person in cup 3 would have a positive genetic test if we ordered it, whereas the person in cup 2 would have a negative genetic test or a normal genetic test. So again, this is to illustrate some of the complexities of cancer genetics, but also to acknowledge that even when we have a normal hereditary cancer genetic test, that does not mean there was no hereditary or familial contribution. It's all a matter of scale. To give you a bit more detail about what that scale might look like, I have a few examples here that illustrate how you might find two patients, both with hereditary risk for the same type of cancer, but what their next step looks like can be very different depending on whether it's a high penetrance or a moderate penetrance gene. And all of the guidelines I've referenced here are referenced with permission from the National Comprehensive Cancer Network's clinical practice guidelines, and I have a complete citation for that at the back. But BRCA1, thinking back to our opening question, that is a high-risk breast cancer and ovarian cancer gene with up to a 70% lifetime breast cancer risk. So for a person unaffected with cancer, they're going to be offered their option of high-risk surveillance starting from age 25. That's mammograms and breast MRIs, alternating every 6 months. And they will also be offered the option of risk-reducing mastectomy. Meanwhile, a patient who similarly has a positive genetic test, but their test is positive for CHEK2, a moderate penetrance breast cancer risk factor with a lifetime risk of about 25%, they also would be offered that high-risk surveillance with MRIs, but it starts at a bit later age, and their risk would not rise to the level where we're talking with them about risk-reducing surgery. We see something similar with colon cancer genetic syndromes, a higher penetrance syndrome being Lynch syndrome associated with several genes, including MLH1, where we're doing colonoscopies from the early to mid-20s and repeating them every 1 to 2 years, versus moderate penetrance PTEN hamartoma tumor syndrome, where we do colonoscopies not every 1 to 2 years, just every 5 years, and begin them at a little later age. I should acknowledge that whether something is considered moderate penetrance or high penetrance, it's a little bit subjective. It can also vary by tumor type. You will see that I called CHEK2 with a 25% risk moderate for breast cancer, but I called CDKN2A with only about a 15% risk of pancreatic cancer high penetrance. Some of that has to do with the chance of that cancer in the average risk population, what fold the increase is, but also some of it has to do with how significant it is a change to the patient's medical management. So we are jumping into the meat of the presentation now, recognizing some of the signs of hereditary cancer. You can consider these hereditary cancer red flags or clues, and typically any one of these would make a patient eligible, if not for genetic testing, at least for additional evaluation to see whether genetic testing makes sense. So if someone has an early age of diagnosis, for most cancers that's defined as under age 50, if the patient themselves has had multiple cancer primaries, And that could be two cancers. So think about metachronous colon cancers that may happen some years apart, or it can be different organs like a breast cancer and an ovarian cancer in the same person. If they have a family history of cancer. Now, most of our hereditary cancer syndromes are inherited in a dominant fashion, which means if a parent has it, each child has a 50-50 chance. So usually when we see family history of cancer, it is more concerning if we're seeing it in several generations of the family. There are a few exceptions to that rule, particularly colon polyp and cancer conditions that can be inherited in a different way, where you may see a high cancer burden in a sibling group, but nothing in the earlier or the later generations. Another hereditary cancer red flag or clue are cancer types that have a higher proportion of hereditary cases. And I will have a whole slide on that in a second to help you recognize those. Then there are just additional features. So, for example, in breast cancer, triple-negative breast cancers are more likely to have an underlying cause, and everyone with a triple-negative breast cancer should be offered genetic testing. And in prostate cancer, that would be the metastatic prostate cancers. Seeing a cancer in the less commonly affected sex, like a male breast cancer. Seeing a combination of cancer with benign neoplasms, like multiple colon polyps and colon cancer together. Or if you have done some somatic or tumor genetic testing in that patient and something reported could have implications if it was in fact hereditary, that's another thing to look for and think about. So how do you know what the related cancers are? For the most part, we know that no gene really increases risk for every type of cancer across the board. Certain genes are related to certain types of cancer. Breast cancer, though, because there are so many different hereditary breast cancer syndromes, breast cancer can go together in a genetic syndrome with lots of other cancer types. The most common one you'll run across is that BRCA1 and BRCA2 hereditary breast and ovarian cancer, with ovarian, prostate, and pancreatic cancers going along with breast. But we can also see lobular breast cancer with diffuse gastric cancer in CDH1, hereditary diffuse gastric cancer syndrome. We can see breast cancer with thyroid, colon, endometrial, and renal cancers with PTEN hamartoma tumor syndrome. And Li-Fraumeni syndrome comes the closest to being a cancer syndrome that increases risk of all sorts of cancer. But in this case, you will frequently see very young cancers, including childhood onset, and you'll be seeing things like sarcomas, CNS system tumors along with breast. With colon cancer, Lynch syndrome is the most common hereditary colon cancer syndrome, and so we would be looking out for not only colon, but endometrial, ovarian, and pancreatic cancers, as well as other GI cancers. Again, for folks who are more visual, there is a great tool from the Journal of National Cancer Institute, their concise handbook of familial cancer susceptibility syndromes. Now, this is the second edition, which is on the older side, admittedly, but I have heard that they are having a third edition coming out soon, so I hope that that will come out soon and you'll be on the lookout for it. In this diagram, the left-hand column lists a bunch of cancers or tumor sites, and then each of the additional columns names a hereditary cancer syndrome. And this is just a small snippet of that graphic. If the box where they intersect is filled in solid, that means that that is a known association with that syndrome. If it's shaded in, there's a possible association with that syndrome. So I do expect that when the third edition of this comes out, we will have more clarity about some of the hatched boxes that we will know for sure whether they are or are not associated with those syndromes. And I also expect that it will include more of the moderate penetrance genes, which were not included on first publication. But this is a handy tool if your patient has a family history of several different types of cancer and you're not sure whether they go together, you could check here. Of course, you could also just refer to your genetics practice or give us a curbside consult and ask us, does this person require referral? As promised, I told you that I would tell you the cancers that always prompt a genetic testing offer. This is not an exhaustive list, but these are some of the either more common ones or more strongly associated hereditary hereditary cancers. So ovarian, and within that, we also consider fallopian and peritoneal cancers, exocrine pancreatic cancers, some less common tumors called pheochromocytoma and paraganglioma that have a real high hereditary contribution, and then adrenal cortical carcinoma. I acknowledge, though, that is all a lot. I went to graduate school for 2 years to recognize all of these features, and I don't expect that every practitioner is going to have the same eye for detail as a genetic counselor would about those red flags. So if that was too much, here's a somewhat simplified tool. It's called the Rule of 2 and 2. And this is often attributed to a pediatric medical geneticist, Arthur Grix, because it applies not only in hereditary cancer, but to a lot of conditions that may have a hereditary basis. So the TOO2s are too many, too young, too different. So these may resonate with the things I was talking about earlier, like having multiple family members who have cancer. That's too many. Diagnosis under age 50, that's too young. There are only a handful of hereditary cancer syndromes where growth is impacted, but if someone is quite short or unusually tall and has a cancer, that might indeed be a red flag for hereditary cancer syndrome, although you won't see that a lot. And then the TWO2s are 2 tumors, 2 generations, 2 in the family, especially if it's a less common cancer type. And again, coming from pediatric genetics, 2 birth defects, or in the cancer realm, I would say cancer plus a birth defect, like a limb anomaly could suggest a hereditary cancer syndrome. All right, so we're closing in on my first recommendation. And I really have to acknowledge that all of these signs and mnemonics, they are only going to work if they are implemented. That includes collecting a family history in a way that is more robust than just asking if anybody else in the family has the same type of cancer as the patient, because we've talked about related cancers that on the face of it may not seem like they go together, absolutely can in a genetic condition. So my first recommendation is just that providers working with cancer patients make screening patients for hereditary risk a routine process. They know that it's going to happen for every patient. They know who in the practice is responsible for it. So this brings us to our first learning check. This is going to be on poll everywhere, but as the question is a bit long, I'm going to read it here first. Patient X has ovarian cancer at age 72 and a large family with no cancers in close relatives. Patient Y is a woman with breast cancer at 49, whose sister had breast cancer at 45, and mother had breast cancer at 55. Which patient or patients should be offered genetic testing for hereditary risk?
All right, and while we're waiting for those to come in, I like the new graphics for the marbles.
Oh, yeah.
I'd seen that before, but
A little
those
different,
are
yeah.
very snazzy.
All right.
How are they doing?
You know, they're doing pretty good. Oh, we can't show the slide. That's okay. So we ended up having about 2/3 people answer patient Y only, and 1/3 of the people answering both patient X and patient Y. The people in the minority are actually correct here, but out of all of the other options, I would expect option B to be the one that tripped people up. And that is because patient Y has more red flags, right? They have multiple people with cancer. They have a young age. They have 2 generations of the family. But patient X has ovarian cancer, and ovarian cancer is one of those always offers cancers. So it's important to recognize that just because one person may have more risk factors, that doesn't mean that the person with fewer risk factors isn't eligible for genetic testing. It does, however, influence who is more likely to have a positive result for testing. And I do think that the people who picked patient Y only, your consolation prize is that I think patient Y might have a higher chance of having a positive result on that genetic testing. But the correct answer, like the board correct answer, if I was teaching my genetic counseling students, would be both patient X and patient Y are eligible for genetic testing and should be offered it. But we are going to reinforce that with the next section and a case. So let's say you have identified a patient who possibly has hereditary cancer risk. They may be overwhelmed with their treatment. Maybe they're even at the end of life, so they are transitioning from treatment with a curative intent to more comfort care. So you might be wondering whether you need to put one more thing on their plate in the shape of a genetic test, or maybe it would be better just to say your relatives should see genetics. So we're going to explore this with a real case. This is a case I saw within the last 6 months. And this is the family history I took. It is modified slightly so that the details are less identifying. I tweaked things like ages. But right in the middle of the figure, you will see a circle, circles representing women and girls, squares, men and boys. The circle in the middle with the arrow is a 44-year-old woman who came to my clinic. She was actually self-referred, but she stated the reason for referral was, mom's oncologist told me that I should have genetic testing. So as I got to know this patient, her mom had died very recently. It had actually been suggested earlier in her mom's treatment that her children have genetic testing, but the patient had been accompanying her mom to appointments, and it kind of led her to delay that genetic testing for herself. Then after her mom passed, she revisited it. So, and I should say too, in addition to the mom who had ovarian cancer, there are some early onset breast cancers in this family as well, including the patient's sister. So because no affected relative was available to test, I tested the unaffected patient, and this is a snippet of her negative result. I want to take a second to say that this is an excerpt from a real patient report. I have removed the lab name, and although you may recognize the format of this test, it shouldn't serve as an endorsement from me on any particular lab. In fact, in our clinic, we use a variety of different laboratories depending on the test we're ordering and the particular patient circumstances. But this test was a breast and gynecologic cancers panel. It had 21 genes, and the genes are listed in the excerpt on the right. Came back negative normal. So the first instinct would probably be to be reassured. But unfortunately, this is an uninformative negative result. And I will walk you through why that is with that same diagram. So we can't tell from our patient's result whether her family members had a big marble and she was lucky enough not to inherit it, or if there's no big marble in her family at all. But if there's no big marble in her family, with ovarian cancer and 2 early onset breast cancers, there is certainly a higher level of that familial clustering risk like cup number 2. And since we cannot tell that by testing just the patient herself, we are going to have to be cautious and manage her based on her family history. So to walk that through just a little bit more detail, there are several different possible explanations for a normal test in an unaffected patient with a family history like the one I showed you. It could be that there is an inherited cancer syndrome in the affected relatives and that your patient did not inherit it. Or it could be that there's a hereditary cancer syndrome and that, unfortunately, the family's variant can't be detected by current testing. Genetic testing is very good, but no medical test is going to be perfect, and there may, in fact, be high-penetrant things that we can't yet detect. Maybe a little bit more likely, if we can identify a cause in the family, is that there's not a true hereditary cancer syndrome, but there's a higher burden of familial risk. And probably the least likely in this scenario is that all those cancers in those young ages, they just happened by chance, and these were separate sporadic cancers. Unfortunately, though, we just can't tell which of those possibilities is the case for any given patient. So what happened for this patient is that I told her, your family history is still showing you to be at high risk, and you should do increased breast surveillance every 6 months, alternate between the mammogram and the breast MRI. Unfortunately, we didn't know if something like risk-reducing oophorectomy would be appropriate for her. Typically, we would not offer that with only a single relative with ovarian cancer. But what if there was a hereditary cancer syndrome that we couldn't identify with current testing? But we couldn't really make a recommendation there. We said each of her siblings who are unaffected also need testing. And since we don't know what's causing cancer risk in the family, they all need a comprehensive or a panel genetic test like the patient had, which costs a bit more. But we also encouraged this patient to ask about testing in her deceased sister, because someone who had breast cancer at 31, at that time, she should have been offered genetic testing, and we wanted to see if maybe that existed somewhere. So this case has a really bittersweet ending. It turns out that the patient's deceased sister had in fact had genetic testing before she passed, and she had a BRCA1 pathogenic variant. But this hadn't been talked about in the family. If mom had known about that about 10 years before when her daughter was diagnosed, she could have been offered testing and had a risk-reducing surgery that prevented her ovarian cancer. And I think that that's really tragic. But for my patient, it means that her results are now informative and they're a reassuring true negative. And furthermore, all of her other siblings were able to get tested with an informative targeted test, which was also more cost effective for them. The brother is positive. He has that cancer risk, but the 2 additional sisters are negative. And I think, too, about that patient who passed away, who wasn't, quote unquote, burdened with genetic testing for herself at the end of life. Wouldn't she have wanted to know that her living daughters all had normal genetic test results and didn't inherit this risk that she had seen impact her sister, one of her daughters, and herself? So I think this speaks to why it is patient-centered care, even for people who may not personally benefit from the results of their genetic testing, to help inform them about their family members' risks and their results. So to reiterate some of the benefits of testing affected people first, sometimes the results do have clinical benefit for the patient, like people with BRCA1 and 2 pathogenic variants responding better to PARP inhibitors. But their test will mean more informative test results for everyone in the family. It's a more efficient use of resources. If a parent is tested and they have negative genetic testing, that means there's no need to test any of their children. If they have positive genetic testing, it means that their children can have a targeted test rather than a panel test. Also, Medicare does not cover cancer genetic testing in unaffected people. So if the affected person's relatives happen to be covered by Medicare, they wouldn't be able to get that testing without significant out-of-pocket or personal cost burden. Whereas if the affected patient is tested first, laboratories often have low-cost or no-cost options for the relatives of someone who's tested positive, making that a lot more available. And then I really do believe that there are psychosocial benefits of being of service to your relatives through having genetic testing. Patients tell us all the time when they get positive genetic test results that we as a healthcare provider may see that as the bad news result. They say, oh, I'm so glad because we just knew there was something going on in our family, and at least now people in my family can be proactive. At least now people in my family will know whether they inherited this risk instead of just living under the burden of all the family history. Right. So some points to consider, though, if you are going to be offering hereditary cancer genetic testing within your practice setting, there are some nuances to what's available. You could order targeted testing, by which I mean a disease-specific panel like the hereditary breast and gynecologic cancers panel I showed for this patient, versus some panels that are pan-cancer. They can include upwards of 80 genes. The pan-cancer panel sometimes looks like the smart bet on the face of it. You don't have to decide. Everything is just there for you, so you don't have to decide which one matches the patient history the best. But it can add a lot of additional complexity. If you get a positive result on a targeted panel, that positive result almost always is diagnostic and explains your patient's cancer. But if you order a pan-cancer panel, you may find something that's completely irrelevant to the type of cancer in your patient and their families. Larger panels are going to increase the chance of uncertain information. While genetic testing labs are almost always able to tell when a genetic variant is cancer associated, it's a pathogenic variant, or whether it's a benign and harmless variant, we do get uncertain results in about 5% of our targeted panels and as many as 25 or 30% of our pan-cancer panel orders. So that's 1 out of 3 patients may get a result of uncertain significance if you order the largest panel. And even if the result returns as a clear positive result, if it's a positive result for an incidental finding, there's still a bit of an open question as to whether the recommended next steps are equally good for people where a cancer syndrome was discovered incidentally versus someone where it was picked up because of relevant personal or family history. And I think because of those differences, you need a longer informed consent discussion for a pan-cancer panel, and that doesn't always fit well into a point-of-care testing scenario where an oncology office or a surgical oncology office are going to be ordering the testing. When you're doing informed consent, it's really important to hit on whether or not there is expected utility for the patient. Is there any chance it would change their first-line therapy or an additional therapy if they progress after the therapy they're on? Let them know about the familial implications of the test so that they're not surprised by being asked to inform relatives about their test results should they come up positive, and hit on the possibility of those uncertain results. So that comes to my recommendation 2. And I am going to say I recommend a targeted genetic testing panel, especially for someone who is not spending a lot of their professional effort doing genetic testing. By focusing on the targeted panels that are specific to the diseases you're seeing patients with, you're going to gain a lot more confidence and facility with doing that as opposed to having to do the pan-cancer panels. And I recommend that you offer those to everyone who's eligible regardless of their individual factors. Again, we may think it's a kindness to not add additional burden onto a patient, but that might actually prevent them from getting desired information for themselves and for their family. So here's our next learning check. This is a 76-year-old patient with a new diagnosis of advanced pancreatic cancer. They don't intend to pursue therapy with curative intent, and they're accompanied to clinic by their son, who asks about his own risk for pancreatic cancer. So I'm asking you to choose the most appropriate next step, which could be to advise the son to meet with a gastroenterologist to discuss pancreatic cancer screening, or to offer hereditary pancreatic genetic testing to the patient, or to recommend hereditary pancreatic cancer genetic testing to the son, or finally to just advise the son that he's at low risk for pancreatic cancer and no changes to his medical management are indicated. This is great. We have a smattering across all of the responses, but far and away, our majority with 75% is choosing B, which is the correct option. Pancreatic cancer, like ovarian cancer, is one of those always offered genetic tests. And since the patient is the one affected, they are the best person to get that test. I will say that it wasn't too long ago that pancreatic cancer was not part of the recommendations as an always test cancer. So some of you who have been in the field for, say, more than 5 years may be remembering the older guidelines, but those have been updated to say that pancreatic cancer now is an always offer genetic testing cancer. Great. Next section. You've now identified someone with a hereditary cancer risk. Your patient has had a positive result. How are you going to support this person in talking with their family about genetics? I will say I always encourage you to refer patients with positive results to genetic counseling, and we are going to help with this. But we often see patients one time, so it really helps to have your partnership in this as well. You have that longitudinal relationship and that trust with the patient that really can help them focus on this. So testing of relatives after an initial case is identified is called cascade testing. And unfortunately, cascade testing success is fairly low in real-world situations. So in a recent meta-analysis of hereditary breast and ovarian cancer syndromes, we found that only 1/3 of at-risk relatives who are eligible for cancer genetic testing get it after someone in their family was identified as positive for BRCA1 or BRCA2. In a really seminal study in Lynch syndrome cascade testing, they compared testing in research scenarios where they were offering free genetic counseling and free testing, and compared that to real-world scenarios where some of those facilitators weren't present. And they saw a decrease of 50% in moving from the research setting, where approximately 6 relatives were tested for every case with Lynch syndrome, to the real-world setting where it was 3 or fewer. Again, this Lynch syndrome cascade testing, I called it a seminal study. It is a little bit on the older side, but it had methodologic strengths that I think a lot of the newer papers have not replicated, which is why I referenced that one. So let's acknowledge some of the barriers. Cascade testing is obviously hard. This is important medical information, but it's not always happening. Why is that? There can be lack of knowledge or misinformation, and that can be on the part of providers and patients. A real common myth is people thinking that you don't need to inform male relatives about BRCA risk, when in fact all relatives, regardless of their sex and gender, should be informed. Maybe the patient knows this is important, but they lack confidence in their ability to explain the information, which either leads them to put off doing it, or maybe they do inform the relative, but they don't highlight the importance for that relative to actually get screened. People worry about giving relatives bad news or the cost for their relatives. They say, well, can I tell my brother this if I know he doesn't have insurance and he might not be able to get the testing? And then sometimes people just have strained family relationships. The closer you are with your family, the more likely you are to share your result and for them to succeed in getting genetic testing. And then another barrier is that a patient may feel overwhelmed with what they're going through with their cancer diagnosis and treatment, and not have the additional bandwidth to be able to inform relatives as well. So there are also facilitators. I already mentioned those closer familial relationships, but some of these are things you would have control over. So you can offer patient education materials to help combat misinformation or lack of confidence. Again, for lack of confidence in explaining, or also for strained family relationships, a Dear Family Member letter is great. These are templated letters that contain all of the pertinent information for that relative, so the affected person can just hand out the letter without having to be the one that decides how to explain things. People have found that just having a supportive healthcare provider also helps facilitate cascade testing, as does access to genetic counseling and testing programs that offer no cost or reduced cost testing. All right, so how can you support, if you want to be supportive of your patients, how can you do that? One is, of course, that genetic counseling referral. Genetic counselors are going to give education and resources. We can help with things like a family letter. But again, I really want to emphasize that they will see us once and they are going to see you over the long term. You can recommend to your patient identifying a cascade testing champion. And what I mean by that is that sometimes people going through a cancer diagnosis, they might have a friend or a relative who says, how can I help you? And they can say, well, I recently found out that I have BRCA, and what would really help me is if you took the burden of explaining that to everybody away and made it your job to tell all of our relatives. So once somebody knows it's their job and they've been capacitated to do that, it might be a little bit more likely to get done. Please make sure that your patient has an actual copy of their test result and they're able to provide it to relatives, because to give their family members the most efficient testing and the most reassuring normal result, we have to be really clear on what the first person has tested positive for, and seeing that test report is the best way to do that. And you can also be aware of other resources you can give to support cascade testing. So when I do my counseling, these are some common phrases I use. If you are going to be approaching cascade testing for the first time, you may want to practice some of these phrases first to counteract any hesitancy to share. I'll have patients say like, oh, my family member is going through a big time. They're having a new baby. They've got a new job. I just don't think now is the right time. But we can say things like, we can't change whether your relative has inherited this risk, but what we can do is make sure they have an opportunity to get the care they need. Or acknowledge this is difficult news to share and there's never going to be a perfect time. But unfortunately, it is possible to wait too long. Our goal is really to help family members learn this information before anyone else has cancer. The CDC has some great resources. I'm not going to talk about them in too much detail, but they have information, they have links out to patient support organizations, and they even have template family letters if that's something that you are wanting to offer. So a couple more recommendations in this area. First, if you have someone who's tested positive for hereditary cancer syndrome, please proactively address cascade testing and check in about the status at appointments. Again, a supportive healthcare provider is a facilitator to actually getting those people tested. And then those people may either avoid a cancer diagnosis or get diagnosed at a much earlier and more treatable stage. So checking in can really benefit people. And also be ready with those resources like the family letter, like the CDC cascade testing page so that you can help people out. Here is our third and last learning check. So this patient has a BRCA2 pathogenic variant. She says she wants to share this information with her sister, but they have a really tense relationship. Which of the following tools would be best suited to overcoming this barrier? We've got options like a reduced cost testing program, a support group for hereditary cancer risk, a Dear Family Member letter, or a BRCA2 infographic. I'm not going to spend long here because already we see 100% with the correct response, which is great. Every single option here is a facilitator of genetic testing, cascade testing, but the Dear Family Member letter really takes the pressure off of someone so that they don't have to have a personal interaction with a family member that they may not be close to. So great job, everybody, on that one. Okay. This is our last section. It's our shortest section, so you're really nearing the end. When should you refer to genetics? At the end of 2023, according to the American Board of Genetic Counselors, there were 6,800 certified genetic counselors. And based on the proportion that report cancer as their primary area of practice, we can anticipate there were about 2,700 cancer genetic counselors among that number. But there were over 1.5 million new cancer diagnoses in a similar time frame. So what that means is that there are not enough genetic counselors to see every patient with a cancer diagnosis, and we really need your help in telling us who needs a genetics appointment. Genetic counselors, we are here to help you. We do not want to put barriers up to patients accessing genetic testing. So we absolutely acknowledge that genetic testing can be done and can be done well in oncology offices, in surgery offices. But here are some times when you might consider a pre-test genetics referral. One possibility is that you've identified that a patient meets criteria for a targeted test, but maybe they need a broader test. They have ovarian cancer, but do they also need a colon cancer genetic test because of their brother with colon cancer? Maybe there are a lot of cancers in the family, but you're not sure if they go together. Or maybe the patient has had tumor genetic testing, somatic genetic testing, and you think something on there might be relevant to hereditary risk. Then, of course, even if you do a lot of genetic testing, you may have a patient that comes with more questions than you are ready to handle, or someone who's really on the fence about testing. They just don't know if it's for them and they're seeking more information. Any of those would be a good reason for a pre-test genetics referral, along with anyone you think may have hereditary cancer red flags that your clinic doesn't have capacity to test. So if you have a hereditary cancer testing program, but it is only for people who very clearly meet a set of circumstances and you want to refer all the other people out, please do. As long as patients are either getting the test or getting referred, that's a win in my book. On the other hand, if you are doing most of your own genetic testing, who should be referred to genetics on the back end for post-test? All the positive results, all the uncertain or the unexpected results like the incidental findings, as well as negative results that you don't believe. So negative results where you said, gosh, this patient had so much family history of cancer, I really expected a different result. Those could come to genetics. Also, if they've had negative targeted testing, but you think they may need something of broader scope. And also know some labs offer a no-cost re-requisition, which means if you refer them to genetic counseling, we can often get additional genes added to their first test if they're coming in within a 3 to 5 month window without having additional cost to the patient. And then finally, sometimes patients will say, like, I have this ovarian cancer, but my kid's dad had prostate cancer. What does that mean? In that case, that's where the child really may need to come in themselves. If they have 2 branches of the family with cancer risk, it might not be something you can handle in your office. So the last recommendation here is just have a low threshold for involving us in cancer genetics. I want you to see 2 additional references. If you want to gain more confidence in identifying people at risk for hereditary cancer syndromes, these are great papers. As promised, here are the full NCCN references, and I do just want to highlight that NCCN is continuously updated with the most up-to-date evidence, so it is always better to refer to NCCN online for the current version than to rely on my slides or anyone else's. And then here are the remainder of the references. Thank you so much for your time, and I think we have a few minutes for questions.
We sure do.
Great.
So thank you so much. I'm just going to go ahead and bring up, wow, we have a lot of questions already. Okay, this is
Great.
good. This is good. So let me go ahead and move over to our slide page. This is excellent. I learned a lot. Okay, so we'll start with this one. Bear with me. It should be up in just, okay. So for some reason, this one is not populating, but
Okay.
I have the question, so I'm just
Sure.
going to go ahead and read those. So how about the insurance coverage for genetic testing for family members? Who will order the testing if the family member is far away?
Yep, that's a great question. So in terms of insurance coverage, most ACA compliant plans will cover genetic testing in someone who's at 50% risk or at 25% risk of a hereditary cancer syndrome based on having a relative who's had a positive test result. We are limited here in North Carolina. We do not have licensure for genetic counselors, and we can only see the relatives who are in the state of North Carolina. But the National Society of Genetic Counselors has a Find a Counselor tool, so we are often able to connect people with local providers who can not only see them, but can accommodate getting them in within that reduced cost testing window if that's applicable. And there are also telehealth genetic counseling services if someone just lives in a really remote area. Sometimes primary care providers can help with that too, but often for the unaffected relative, it will be through a genetics clinic or a genetic counselor.
Great, Kate. Thank you so much. Here's another one, and we hear a lot about AI. Can you take the time to explain how AI is being used to expedite your discussions, if in fact that's the case?
Yeah, so I would say that that's not something that we're exploring at UNC right now, but I am aware of mostly chatbot tools that are being used in other clinics, usually still in research settings, and usually for really clear-cut indications, like in the setting of metastatic prostate cancer, where every man with a metastatic prostate cancer should be offered genetic testing. There's been developments of chatbots that use AI to help answer questions in an informed consent process. But that's not something that I have personal experience with, apart from reading the literature.
All right. Thank you so much. Talk a little bit about the costs, because you've referenced costs several times, and but I'm assuming that both for insured and for uninsured, it's more than a checkup. And
Yeah.
without getting into too specific, what kinds of costs are we tending to look at?
Well, so although I did say several times that a panel is going to cost more than a single gene test, the good news is that for most patients with a commercial insurance plan, genetic testing is a covered service, especially for people who have cancer. Added to which, people who have cancer typically are meeting their out-of-pocket costs. So even if they do have some co-insurance or deductible, that might not apply anymore by the time that they have their genetic testing. So I think that in our clinic over the last year or so, over 90% of our patients had an out-of-pocket cost of $250 or less.
Okay.
That being said, there are sometimes some real outliers depending on specific niche insurance plans.
Gotcha. This one came up a few times. Are these testing principles similar to other disease processes such as diabetes or heart disease? And there were a couple of other questions along those lines. What's the applicability to non-cancers?
Yeah, that's great. So for any condition that does have a similar contribution of single gene disease, a lot of these are similar principles. So that rule of 2 and 2, that actually came out of the pediatric general genetics background. For things like common heart disease and diabetes, we don't really know of any large marble risk factors for those. They are all multifactorial. So currently we don't have good genetic tests for those sort of thing. The exceptions would be some sort of rare types of heart disease, different arrhythmias, hypertrophic and dilated cardiomyopathies, et cetera, where there are some known single gene conditions for those.
All right, thank you. And then kind of a topical question. There are commercial services that people can use for genetic testing. Is there relevance? First off, is there relevance? And then secondly, with one of those companies under bankruptcy proceedings, do you have any special thoughts on privacy for patients where that personal information is being housed by a company that's under bankruptcy?
Yeah, that's a great question and a broad-reaching question.
Yeah.
But first, with respect to kind of commercial testing or testing that is consumer-initiated as opposed to happening in the context of a health visit,
Yeah.
it's a little bit of a buyer beware. Some of the companies are CLIA and CAP certified. Those are ways of kind of certifying that a laboratory is doing a good test, and that's a standard for clinical labs as well. But just because they have those accreditations doesn't mean that their test is of the same quality. So one, for example, even had FDA approval to return some hereditary cancer results. But if they were looking at the BRCA gene, they were returning about 50 different variants in the BRCA gene, whereas a clinical grade test would be returning any variant that was identified in that gene rather than a select subset. So I do think it's buyer beware. It is typically going to be best to go through a clinician who understands all of these complex nuances of what genetic tests are available, which ones are clinically validated, when is it a genotyping test looking at specific variants versus a sequencing test that's going to give you a more broad look. With respect to privacy, I think to some extent the cat is out of the bag with that. A clinical laboratory is typically not going to be sharing data with commercial partners, although they may be doing research in-house for new test development or doing quality control, those sorts of things. So that's another advantage, I think, of going the clinical route. The testing that we are talking about here, hereditary cancer genetic testing, since the scope is small, even the biggest panels only have about 80 genes out of the 200 or 20,000 human genes in the body. Having genetic testing for cancer leaked is probably a low security risk. And furthermore, there are protections, specifically the Genetic Information Non-Discrimination Act, that protects your employment and your health insurance from being impacted by increased risk genetic test results. Unfortunately, that law doesn't protect life insurance, so there are some at-risk results that could have an impact on folks.
Gotcha. Thank you so much. And phenomenal questions today and phenomenal attendance. We had over 130 attendees
Oh, that's
today.
amazing. That's great to hear. Thank you again for spending some time with me today.
We really appreciate that. I hope you'll stay with us to the end. We do have one slide that we're going to put up at the very end that we neglected to put up earlier, just a disclaimer that we need to show you. So let me see for, there we go. I want to say thank you to the state of North Carolina, the University Cancer Research Fund funding all of the work that our group does, the UNC Lineberger Comprehensive Cancer Center. We want to thank Benny Obore, John Powell, Oliver Marth, Andrew Dodgson, Patrick Muscarella, Barbara Walsh, and Kimberly Riddick. Kimberly is joining us as our new nurse planner.
Great.
So, yeah.